Thank you so very much for inviting me to speak with you all today. I'm looking forward to sharing a little bit about what NCQA is doing in terms of measuring quality at health plans and what the future looks like for measures, including digital measures. The HEDIS stands for the Healthcare Effectiveness Data and Information Set. This is a set that is used by more than 90% of America's health plans. We are able to compare health plans across important dimensions of care and service, including preventive services, behavioral health services, coordination of care, and overuse and appropriateness. We have seen a very positive trend over the last 10 years. This is actually a 20-year view of the millions of members who are enrolled in health plans that report HEDIS data that is audited by the health plan. We saw in the year 2000 that there were 50 million members enrolled in these plans. Now nearly 200 million people enrolled in health plans that report HEDIS data. The most recent year of HEDIS data set includes 92 measures across 6 domains. It includes utilization and risk-adjusted utilization, health plan descriptive information, effectiveness of care, and these measures are used very widely in programs, including CMS's ACO programs, CMS's quality rating system, which measures the marketplace plans, the Medicaid adult and child core set. So HEDIS measures are widely used to hold entities accountable, whether they're Medicaid plans or commercial plans or Medicare health plans. When we develop measures, we are looking at several pieces of the pie. Measures have to be relevant and meaningful to patients and providers. They should address issues that are important to improving health. There should be substantial variation in the performance. Otherwise, it's not a useful measure to distinguish performance. And it should be within the control of the clinician or the clinical team to do something about it. So that's relevance. The second characteristic is scientific soundness. We take pride in basing all of our measures on the best evidence. And that is really crucial to the buy-in of health plans and clinicians both, in terms of understanding that these are measures that are measuring what's good for their patients. Measures also need to be accurate and reliable and valid. So we have to be able to get good data into the measure and a reliable result out. Finally, feasibility is really where the rubber hits the road, because the measure needs to be specified so precisely that everyone does it the same. And that's the only way to compare apples to apples. We need to make sure that when we create a measure that the needed data to complete it are available and universally available. The cost of data collection is sometimes an issue. We need to make sure that that's reasonable. And finally, the measures need to be auditable, because NCQA runs an audit of all our health plan measures. The data sources that are used, so we talked the slide before about data needs to be available. The data landscape is changing rapidly. And so what was created 30 years ago when HEDIS was created was a system where either a measure was administrative, so it used enrollment data or claims data, or it was hybrid, which meant that there was a chart review component to it. There would have to be a sample and a chart review. And then finally surveys. So you're probably all familiar with CAP survey, the Medicare Health Outcomes Survey. What we've done in the last 5 years is to create a new kind of measure that is looking at electronic clinical data systems. So a measure that uses multiple kinds of electronic data that can all flow into the measure. And by all kinds of clinical data systems, I'm referring to electronic health records, registries, case management systems, as well as claims, which are, of course, an electronic source of data. If you would like to learn more about our electronic clinical data system measures work, there's a website here. You can go and look. Easy to remember, ncqa.org/ECDS. Now, we are careful to explain to folks who may be new to measurement that not all good ideas can make good measures. If there's a clinical shortfall, usually it's because science is changing rapidly and the measure, is outdated by the time it's created, or there may be a need for risk adjustment and none that's available. There are technical problems that can happen, like if everybody that you're going to measure has a very tiny number of patients to whom this measure would apply, then you're not going to be able to use a measure like that to compare clinicians or to compare health systems or to compare health plans. And then external issues are really about understandability. So can users understand the results? Can accountable entities control or influence the outcome? And in particular, where there are differences in delivery systems or regional differences across the United States, sometimes that is troublesome to our approach, because we want to make sure that we're making a fair comparison all across the country. So the HEDIS measure development process follows a pretty standard set of steps. We have ideas, we select from among them, we develop a measure, it goes to public comment. We have something called first year evaluation, which is the first year a measure is in use. It is not publicly reported, but we take in the data and we review it to make sure that the measure is performing as we thought it should. And if that is all, if everything looks good, then it can be voted to be publicly reported the next year. And then we do ongoing evaluation of our measures. And ultimately, our hope is that measures will so-called top out. So everybody will be doing the thing that we're asking them to do all the time, and then we can retire the measure. So NCQA is really committed to quality measurement using objective measures, and in particular, providing an impartial third-party evaluation and audit. We have quality programs, including physician recognition programs. So there's a diabetes recognition program, and we release our measures in Quality Compass, which is viewable on NCQA's website. I'm going to now pause and talk a little bit about a colorectal cancer screening measure, because I understand that you are all interested in cancer screening and that there are, potential areas in particular that you're interested in looking at. And the story of the colorectal cancer screening measure is about the story of concerted incentives, because we have this measure that the current measure looks at adults aged 50 to 75, although we're working on adjusting the measure. The U.S. Preventive Services Task Force lowered the age of starting colorectal cancer screening to 45, and so we're working to update our measure to use that time frame. And it looks for people to have had one of these cancer screening tests in the last year, 5 years, or 10 years. And there are some exclusions to the measure: folks who are frail or who have advanced illness or who have already had colorectal cancer, and therefore screening is not really appropriate for them. So the data that I'm going to show you shows us that the commercial health plans are not moving very quickly, but Medicare plans are. So this is the average national performance on the colorectal cancer screening measure from 2010 to 2018. And you can see that Medicare in red started lower than commercial, but has risen way up to 72%, while commercial has increased a little bit over that time from 56 to 62%. Next, I'm going to show you some box and whisker plots. These are a way to present data that shows the maximum, the minimum, the interquartile range, 25th to 75th percentile, and then the median in the middle there, that line, and the X is the mean. So commercial health plans, and this is looking from 2014 to 2018, the 5 years, really consistent performance of around 60 to 62% on the mean of their patients are getting colorectal cancer screening. And the number of commercial health plans that have surpassed the Colorectal Cancer Roundtable's goal of 80% being screened is only 10. And if you could sort of rethink about this and understand that Medicare health plans are graded by CMS in the STARS program, and getting a high mark or 4.5 stars or 5 stars is really beneficial financially to the health plan, because they get bonuses and they get other benefits that really make it a high value exercise to try and improve all of the measures that are in the CMS STARS program. And colorectal cancer screening is one of them. So since 2014, we see this steady move up in the mean, and the 75th percentile, which was at about 72, is now at 80. So the health plans are really moving their efforts on improving colorectal cancer screening in the Medicare population. The number of Medicare plans that have over 80% screened, look at this, from 25 in 2014 to 105 in 2018. So that is really the story of what a measure can do when it is joined with an incentive program like CMS's STARS program. You can really put together a clear case to health plans or other responsible entities as to why they should improve. And so that is what I wanted to tell you about today. I appreciate the time, and I look forward to the discussion at the end. Thank you.